Hello and assalamu alaikum everyone. This talk will be brought to you today by Dr. Ahsan Rizvi without hopefully any commercial interruption. So I'm hoping that you will enjoy this talk, which is on hospital cases in geriatrics. Just a brief introduction of myself. I'm an American board certified physician in geriatrics and palliative medicine, and I currently work at the Mayo Clinic with expertise in inpatient complex cancer patient management, as well as palliative symptom management. And so I've tried to simplify this presentation so that it can reach to a larger audience, including medical students, residents, young clinicians in practice. And the aim is really to help everyone understand the basics of geriatrics. This is not a high-end, high-level presentation. It's mostly geared to help you understand the basics of what you need to be focusing on when you're taking care of geriatric elderly patients in your hospital or clinical settings. I would like to acknowledge Dr. Donna Miller, who's a distinguished colleague of mine in helping with these slides. I have no financial disclosure. And the learning objectives for this talk are really to help all of us understand and recognize the importance of function in the approach to geriatric patients. How do we determine what's an appropriate blood pressure and hemoglobin A1C target in the older adults? How to avoid prescribing pitfalls in the elderly patients? And how do we identify delirium in the hospitalized older adults? So some of the very high yield topics that keep getting tested in geriatrics. Now, since my hope is that this talk will be shared in amongst the Pakistani and Asian audience as well, I will make some cultural and social references in Urdu to make the talk more relevant to our Pakistani audience. So hopefully it'll be well received. So before we go forward, I think the basic understanding that I want you all to take from this talk are the geriatric 5 M's. What do they all stand for? Most importantly, what matters? So whenever you come across an elderly geriatric patient who is sick or frail, what I want you all to think about is ask the patient about what their goals are and what really matters. Why are they here in the hospital? What goals do they hope to achieve? Which could be anything from, you know, getting out alive from the hospital, going to attend their son's wedding, their granddaughter's graduation, or just simply living as long and healthy as possible. And so how do we discuss advanced care planning, which is a very alien concept in Pakistan, because I've personally been involved lately in my own family, and it's a very difficult conversation to have. And so I'll give you a framework in the next slide to kind of help set up that conversation. Even if it is not going to be conclusive, at least you can get the conversation started. Secondly, mind. So as I said, you know, the most important thing in the geriatric patient is function. Along with function, it's cognition and their ability to remain independent for as long as possible. So addressing cognition and mental health, including depression, anxiety that develops in elder age as a lot of parents end up living alone as their children move out of the house in a different city or in a different country. And then how do we mitigate and understand their sensory impairments, their vision issues, their hearing loss, and all those things that end up being social dilemmas, and therefore people avoid social interactions to avoid embarrassments. Mobility, optimize functional status and maintaining safe mobility. How can we look into keeping our elderly safe with mobility, if they need a cane, if they need a walker, or if they just need, you know, better shoes or a cleaner environment in the house to help them move better. Moving on to medications. as the fourth M, very important. We will talk about this in the upcoming slides. And then finally, multi-complexity, navigating healthcare settings and transitions. And how do we help them live with multiple chronic conditions? They have arthritis, they have diabetes, they had a stroke, they had a heart attack, and now living in heart failure. How can we help them? This talk is all going to be. So as I was talking, what matters? Culturally, we are very, I think we are very disabled, and it's sort of a disability for a lot of us growing up in extended family environments where we have a lot of influences, in our loved ones' decision makings. The chacha, mama, taya, popi, everyone's talking about what should be done to the patient, but the patient. And so what we really need is to see and ask, what does our patient need? Because the needs of the patient come first. Everything else is secondary. So often, you come across a situation where you're asked by a patient's family member that, अब्बा को ना बताइएगा, उनको हार्ट अटैक आ जाएगा, वो दिल के बहुत कमजोर हैं, उनसे ये सदमा बर्दाश्त नहीं होगा. And I always tell my patients that imagine a situation where somebody was robbing your father's bank account, and every day you knew that the money was less and less in his bank account. Would you tell him, or would you hide that information from him? And if the answer is that you would tell him so that he can save his account and take precautions, then how can we be so irresponsible when it comes to their own life? So if there is a threat to a patient's life, whether it's by a chronic illness, cancer, diabetes, stroke, heart disease, whatever it might be, the patient has the right to know what the details are and what risks they can mitigate to prolong their life in a healthy fashion. So good is a fair mnemonic where approaching life-sustaining treatment conversations with older adults, which is goals, again, as I was talking about, and what matters, is first try to understand what the patient knows about their condition. Now, in a lot of Asian culture, health literacy is often very poor, even in the day and age of Google and Instagram and all these social media websites. Our health literacy still remains poor, and we put no effort in improving our overall understanding of our health conditions. And so understanding what the patient knows about their health condition, first of all, is very important. And so that you can help identify what their goals are, what their understanding of their condition is, so that you can take the conversation to the next step, which is reviewing treatment options and expected outcomes. So somebody's coming in with florid heart failure. They have their JVD all the way up to their jaw. Their legs are, full of 3+ edema. Their lungs are full of crackles. And so when you lay out the plan that they would need IV diuretics, and in this attempt, their blood pressures could fall, they may need to be in the intensive care unit. All of those options and expected outcomes need to be discussed with the patient and the family very carefully. And then elicit patient's opinion. What do you think? Here are the options. What do you have to say about all this? Now, they may say, yes, I agree with your plan. Or they may say, nope, I've lived a good, healthy life. I don't want anything to do with being in the ICU on a ventilator. Don't attempt a CPR. And if they guide you towards that goal that they have, then document that very clearly and make sure that the family and the loved ones have a good understanding of their parents or their elderly's wishes. Another good mnemonic is remap, which basically is similar to what we were just talking about in good. And that is reframe, meaning that you assess the patient's understanding. And if they say, or the family members suggest that, but they were just fine up until a week ago, and They were up and walking and doing everything, and now they're coming in with a stroke and cannot barely move. Then a good statement to often use is, we're in a very different place now. Last week, last month was a very different time, and now, given his current situation, we are in a very different place. And that can often bring people um, to the current reality that you might be dealing with. And then expect emotions. We are often very ill prepared to deal with patients and their loved one emotions. I mean, I remember the time when um, house officers would run and hide because they, just told a family member that their loved one passed away, and um, family members often get really angry and agitated. And so, uh, expect the emotion. I think often sometimes the best response is just silence. Just hold their hand, sit with them, um, express that you are sorry for them, and that you had to share this news with them, and just sit quietly and wait for them to ask the next question. Um, and then once that emotional um, burden is crossed, then you can elicit goals and discuss the treatment options and desired outcomes. And then validate patients' goals. I mean, if they say something that you personally think that it's not achievable, at least in that short term, try to modify your plan such that at least it meets with the patient's goals. Um, and give it your best. If their goal is to make it to their daughter's wedding or their grandson's graduation, we should do anything and everything that we can possibly do to help them get to that goal. Whether would it be fully on their own two legs, or they might just be able to wheelchair to that event. But if the goal is to get to it, we should all work together to make that happen. So let's review some cases. And I think that will give you a clear idea now that, let's say you're working in a hospital environment, and you start your rounds, and your first patient is an 82-year-old retired school teacher who has a history of hypertension and is admitted with a vertebral fracture from a fall for pain control. Her medications are hydrochlorothiazide 25 milligrams and lisinopril 40 milligrams once daily. As you can see, the vital signs are fairly stable until you check her orthostatic blood pressures, and those dip from a supine value of 122/74 to a standing blood pressure of 98/76, and she feels a little lightheaded. You check her labs and you notice that her sodium is slightly low, her BUN is elevated, and so is her creatinine, and her glucose is normal. Her urine and chest X-ray and ECG are fairly within normal limits, and the ECG just shows left ventricular hypertrophy secondary to long-standing hypertension. So this picture basically highlights what we understand as how does our body maintain blood pressure. And as you can see, as our BP and cardiac output falls, the baroreceptors will sense the change and will increase the sympathetic tone, and therefore increasing the vascular resistance and heart rate and elevate the blood pressure. But as the body ages, that baroreceptor response basically becomes slower. The parasympathetic tone and the increased sympathetic tone becomes slower and blunted. The blood vessels are already very stiff, and the heart rate response becomes blunted, resulting in a fall in blood pressure, and augmented by medications and hypovolemia from dehydration. All of that then ends up increasing the risk of orthostatic hypotension, I apologize. So less reserve to handle changes in position or fluid status as the body ages. And as we all understand, that orthostatic hypotension is defined as a decrease in the systolic blood pressure by 20 millimeters of mercury, or diastolic blood pressure drop by 10 millimeters of mercury, or an increase in heart rate within 3 minutes of standing. So now, having known all of that information, which of the following is your target blood pressure for an elderly geriatric patient? And let's review these answers in the light of the information in the next slides. So the overall guidelines and consensus statements for our geriatric patients, you know, ideally for the elderly old above 80 years of age, it should not be any lower than 130 over 65. But what I always say is let the function be your guide. So if a patient is functionally robust, active, physically independent, then keeping the blood pressure targets close to 140 to 150. And if they are frail and very old, above the age of 80, then maybe keeping it close to 150. And the JNC8 guidelines in 2014 suggested that treat when systolic blood pressure is above 150 and target to keep it less than 150 by 90 in the elderly old patient. But again, let function be your guide. If it's a functional patient with less risk factors, with low risk of hypotension with medications, avoiding polypharmacy, not too many multiple blood pressure medications, then by all means keep it less than 140. But for the elderly old with prior risks of an ischemic stroke, I think lowering the blood pressure too much risks falls and injuries. And so keeping it close to 50 is a good number. Previously in the SPRINT trial, what they concluded is that among patients at high risk for cardiovascular events, but without diabetes, targeting a systolic blood pressure of less than 120 as compared to less than 140 resulted in lower rates of fatal and non-fatal major cardiovascular events from any cause, although significantly higher rates of adverse outcomes were observed in the patients which had the intensive treatment group. And a serious adverse event was defined as an event that was fatal or life-threatening, including hypotension, syncope, electrolyte abnormalities, acute kidney injury. So things to remember is that low blood pressures in the oldest old with frailty is worse than high blood pressure, and therefore lower blood pressures will increase the risk of falls and other complications. And surprisingly, high systolic blood pressure was not a risk factor for mortality based on the studies that are highlighted on the page. In the oldest old, greater than 80 years of age, targeting systolic blood pressures less than 140 are often associated with higher mortality. So I always tell patients and their family members to not worry so much about the numbers, but what is the patient's overall state of health? Are they robust versus they're frail? If they're frail, then you need to be more conservative and allow for a little bit of what I call permissive hypertension. But if they are robust and otherwise healthy with less risk factors, then certainly control them to close to 140 millimeters of mercury. Moving on, whether you talk about midlife hypertension or late life low blood pressures, ultimate result ends up being ischemic insults, macrovascular disease, cerebral hypoperfusion, ischemic changes, which end up leading to cognitive impairment, dementia, and unfortunately increased mortality. Therefore, obtaining blood pressures on a routine basis and maintaining them in a healthy range is what's more important rather than just being fixated on a number. So what is the optimal blood pressure target? Let function be your guide as opposed to just a number. If it's a robust, healthy, independent patient, then treat as per the JNC8 guidelines and keep the blood pressure systolic less than 140 to 150. But if it's a frail patient with multiple comorbidities, cognitive impairment, then evidence is insufficient to suggest a benefit of very strict control. So individualized treatments based on patients' overall state of health and frailty. Continuing with the case, you appropriately held her diuretics and lisinopril because we noticed that she had an acute kidney injury. She was orthostatically hypotensive. And the nurse calls you at 2 o'clock in the morning that her systolic blood pressure is now 170 over 80, which has been labile somewhat in the past 24 hours, ranging anywhere between 130 to 170. But the patient is asymptomatic. This is 2 in the morning. So one thing that I always ask my nurses is, why are we checking the blood pressures at 2 in the morning? Why are we not letting the patient sleep? And the more important things to check for is the trends of their blood pressure in the hospital rather than just one isolated number. So what do you recommend now? No medication changes, change vital signs to every 4 hours while awake, resume the lisinopril, give them a dose of oral labetalol, or give them a dose of IV hydralazine. So a word about the as-needed antihypertensives in the hospital setting. Asymptomatic acutely elevated blood pressure, there's no published evidence for short or long-acting benefit to treatment. And there's often risk for harm because you may end up giving somebody oral labetalol or hydralazine in the middle of the night, and the next morning they get their routine scheduled antihypertensives, therefore resulting in bradycardia or hypotension and a fall event in the hospital. So I always look at these inpatient, hospitalized patients receiving IV as needed antihypertensives. Only 84% who received the medications had a systolic blood pressure less than 180, and half of them had a subsequent oral blood pressure medication adjustment. So when we're dealing with an acutely elevated blood pressure in the hospital setting, think of patterns and common sense to use guide management. What is their normal blood pressure usually run at 2 in the morning in the hospital? What is the value of a supine blood pressure? Could they have supine hypertension? Are they on other medications that can increase the risk of hypertension? Are they on steroids? Are they on IV fluids? Are they in pain? Are they nauseated? Are they in any sort of physical distress that could raise their blood pressure at such a time in the morning? So do a quick assessment rather than just reflexively ordering medications to fix something that does not need fixing in an asymptomatic patient. All right, moving on to the next case. That of the cake was just delightful. So let's talk about an 84-year-old woman with dementia and hypertension who felt dizzy after a social event at her place. Systemic review is absolutely negative, except for some chronic vision changes, hearing impairment, and aches and pains from arthritis. Her urine labs come back and they show bacteria, but no white blood cells, and 2+ glucose. Her BUN and creatinine is normal, and her random glucose is 250 milligrams per deciliter. So the question is, her blood pressure is 145 over 80. She has no fractures or injuries, but now it's 11 p.m. And after the ED evaluation, she's being admitted for observation. So in addition to orthostatic vital signs and gait evaluation, what is your plan? Antibiotics, fluids and insulin, check a hemoglobin A1C, or get a PET CT scan and a paraneoplastic acid panel. So let's look at the data. So her diagnosis practically is hyperglycemia, glucosuria, and bacteriuria. And what people often mistake is treat asymptomatic bacteriuria, which should not be done. So if the patient is coming in with asymptomatic bacteriuria and you just found bacteria on the urine without any evidence of dysuria, fever, or an elevated leukocytosis or lactate or anything to suggest that she has an infection, do not treat asymptomatic bacteriuria. That's really the bottom line. So now that her hemoglobin A1C is 7.3, what would you do about her new diagnosis of diabetes? Remember, she's 84 years old. Since admission, she has received 6 units of insulin for glucoses ranging from 120 to 220. Her creatinine is 1.4. So do you just do basic diabetes education? Do you start her on metformin? give her on insulin sliding scale or start her on insulin glargine. So diabetes in the elderly old patient is a very sensitive topic. I mean, again, just like blood pressures, the key points to keep in mind is that do no harm first. Okay, so the idea of very tightly controlling their blood sugars may end up causing hypoglycemia and risk of accidents and falls, as opposed to a more thoughtful approach towards diabetes. So as we know that the microvascular and the macrovascular complications typically develop after 8 to 10 years of developing diabetes. Now, if you're diagnosing somebody with diabetes for the first time at the age of 80, what significance would we really have to worry about microvascular and macrovascular complications at that point? There's very little data that is helpful in that age group, and therefore you need to be very mindful about the risk of harm rather than the risk of rather than any benefits that may come from a very tight control. As we all know that the recruitment intentionally stopped in the core trial due to frequent hypoglycemic events. So an individualized glycemic management should have a multi-step approach. So again, estimate the benefits of intensive control. If they're coming in with a hyperosmolar non-ketotic state, then by all means be more intensive with an insulin drip and subcutaneous insulin to control their blood glucose. Estimate the harms of intensive control. Are they living alone, or do they live with someone who can monitor their blood glucose more closely? What resources do they have? Or the lack of resources could put them at risk for harm at home if they're by themselves. And then individualize the target. I mean, yes, by definition, you want to be as close to, less than 7. But for the older patient, even a range of 7.5 is acceptable, as long as it does not lead to hypoglycemic events and does not increase their risk of mortality. And minimize polypharmacy. If you are choosing to treat with oral hypoglycemic agents, always look at their renal function, their hepatic clearance. There are other medications that can interact with oral hypoglycemics or insulin and increase the risk of hypoglycemia. So minimize polypharmacy. Choose one agent and do not add the other agent unless the first agent has not yielded the desired. So what is the A1C target in older adults? In the healthy patient with few comorbidities and intact cognition and function with a normal life expectancy, I would say that a good goal is 7.5% and less. But somebody who is very poor health, complex, very dependent on caregivers for activities of daily living and have cognitive impairment, controlling them too tightly will probably increase the risk of harm to them. So for such patients, an A1C goal of less than 8.5 in a monitored setting is certainly desirable. Another resource that I would like to hint you guys towards is, in the Journal of American Medical Association, Care of the Aging Patient Series, and the link and reference is there on the slide for you guys to be able to just copy and Google it on the web. One good thing about having these talks and discussions in the digital age is that I can just advise you to go ahead, look it up and Google something, which you should be able to do your own pretty easily. So what is the optimal A1C target in the older adult? Again, let function be your guide. If it's a robust, active, healthy, otherwise independent elderly patient, then consider an A1C goal of 7.5%. And if it's a frail, very complex, multi comorbidities, cognitive impairment sort of a patient, then by all means stay a bit more liberal and with a less tight A1C goal. And the treatment should be aimed at avoiding short-term problems like hyperglycemic symptoms, osmotic diuresis, polyuria, thirst. And so just focus on the patient and their function to be your guide as opposed to a number. All right, moving on to the next case. The little children here are nice. Now, you've been consulted on an 84-year-old man who was post-op day 2 after a hip fracture repair. And the indication for the consult was altered mental status. Baseline, they have occasional short memory term issues, as the family tells you. And currently, they're quite sleepy and they're just not themselves per the family, and they're having visual hallucinations. Which of the following would be a rapid, reliable, and cost-effective way to diagnose his condition? Meaning sasta and tikau. So what will get you to the diagnosis of delirium in the most cost-efficient manner? And so the confusion assessment method is what I would recommend, which is basically looking into an acute onset with a fluctuating course, inattention, altered level of arousal, and disorganized thinking. All of that present means delirium. Now, delirium can be hyperactive, meaning hyper agitated, combative, behavioral discontrol, or they could be very somnolent and sleepy or stuporous, or as we call it, hypoactive delirium. And sometimes you have mixed delirium, which has features of both. You have inattention, and then there is the altered level of arousal, as we talked about, and then there's disorganized thinking. And how do we ask about disorganized thinking? Would be simple yes and no questions. Does the stone float or sink in the water? What is heavier, 2 pounds or 1 pound? And if they cannot answer you properly, then they certainly have disorganized thinking and therefore delirium. Now, which of the following is the best method for bedside testing of inattention? Orientation to person, space, and time. Save a heart, hand squeezes, which basically means that you have them hold your hand and you tell them that I will say save a heart. And every time I say at the alphabet A, you squeeze my hand. And so if you say it and on A, they are not squeezing your hand, that means they're not paying attention. So that's again a sign of inattention. Months of the year in the reverse order is another way. Ask them to start with December and go backwards. And if they have trouble naming the names of the month of the year backwards, then that's again a sign of inattention. And so attention testing, use a verbal method. And as we asked what would be a good bedside method, the months of the year in reverse order has the best sensitivity as compared to save a heart, which is often something we use on the bedside, but a better sensitivity for the time is asking them to tell you the months of the year in reverse order. All right. Moving on to the next case. I'm otherwise doing pretty great. And so let's talk about a 92-year-old retired firefighter pilot who's admitted for weakness and urinary tract infection. They have a history of atrial fibrillation. They have hypertension, urinary incontinence, BPH. They live alone at home with their wife and have had no falls in the past year. So the question I always ask is the fall risk on our radar? Do we think that a 92-year-old with so many multiple medical problems who's coming into the hospital could be at a fall risk? And is the fall risk on his radar? Is the patient aware that they could fall or have they fallen or had a near fall somewhere in the recent past? So let's talk about a fall. A fall is an event where an individual comes to rest on the ground or another lower level surface without any known loss of consciousness. Now, if you would have loss of consciousness, that would be considered syncope, where you would have a brief loss of consciousness and a spontaneous recovery within a few seconds. So that's the definition of fall versus a syncope. So keep that distinguishing feature in mind. And when we talk about a mechanical fall would be caused purely by a process that involves a physical agent, not because of a chemical or biological change, meaning that you took a medication, a nitrate for blood pressure or a diuretic for heart failure, and that dropped your blood pressure and you felt. That would not be a mechanical fall. A mechanical fall would be either secondary to uh, arthritic pain in the knees, or you stumbled over a piece of a carpet or rug, um, or just tripped over, the sidewalk or the footpath. That would be considered a mechanical fall. Causes of falls are so many that it's very hard to even put in one slide. Um, and if you look at our falls data, which shows that a large number of inpatient falls are associated with toileting, but generally it's not the toilet's fault. So what causes falls and falls in the hospital setting? Um, Too many hooks and wires. They try to get out of the bed and they get tangled with the IV pole, or they get, uh, you know, uh, hooked by the ECG leads. Um, those are all the physical barriers that we create for patients in the hospital setting. And so a fall risk assessment in the hospital setting is very important, with a timed get up and go test and a bedside mobility assessment test. Again, both things that can go on for a whole separate talk on a different day. But for now, just remember the timed get up and go and the bedside mobility assessment tool, which can help understand um, how much the patient is at risk for falls or how well they're able to get up and get around by themselves. Versus there are intrinsic events, like they came in with a seizure, they had a syncopal event. Well, that could be either because of a pathologic or a pharmacologic issue. Or it could simply be an accumulated effect of multiple impairments. They can not see so well. They are on multiple medications. They have multiple rugs and carpets or clutter just laying around the house, which you stumble upon. And when we review this patient's medication list, voila, here's just a whole list of medications that you keep getting prescribed and prescribed and prescribed, and more prescriptions. One thing that I can tell you with personal experience through our extended family in Pakistan is that we sadly don't have a concept of continuity of care, meaning that no one goes to a same single doctor or physician or office for their entire life. So they go doctor shopping. I went for my head was hurting. I went to the doctor. They told me I had blood pressure, but they don't know. My blood pressure is always in the 180s and 160s. So that's normal for me. And they gave me a medication. I didn't really care about it. So they go to the next doctor to hear what they really want to hear. And that is, oh, you're perfectly fine. And you should not take any medications. And so we hop from doctor to hear what we want to hear, and end up in emergency departments in the cases of, a cardiac arrest, stroke, heart failure, uncontrolled blood sugars causing us, altered mental status and all the complications. So sadly, because of that, we run into a prescription cascade. You went to one doctor, he prescribed you X medications. You went to the next doctor, he prescribed you Y medications without even stopping the previous ones or looking into what the previous medications were, because there's no medical record. So that's a huge challenge. And I want you all to be very mindful. What I always do is I just ask the patient and their loved ones to, can you just bring all your medications that you take from home so I can take a look at what you're on? And that way you can make a full assessment of what medications they're on, what is their understanding of why they're taking it, when they're supposed to take it, how long were they supposed to take it. Maybe that was a medication they were supposed to take for just a few days. If they continue taking it because they didn't really remember or didn't understand what the medication was for. So I always ask what this medication is for. What do you think you use it for? And if they know the indication, great. If they don't, then that's your cue to help them understand why they're taking this medication and what could be the potential side effects. Geriatric pharmacokinetics change as our body's composition changes. I mean, as we grow older, we have more fat versus muscle. And so drugs are absorbed in a very different way. Hepatic first pass metabolism is compromised, renal excretion, the GFR goes down. So the risk of drug toxicity goes up. If at age 40, I was able to tolerate 50 milligrams of something, at age 80, that 50 milligrams could be potentially toxic because my body is not the same anymore. And so the prescribing pitfalls, one thing I want you all to be cautious about is the prescribing cascade, that a new medication gets started to treat the side effect of another medication. And you start another medication to treat the side effect of another medication. So you started oxybutynin because you had urinary frequency and incontinence. Now you have urinary retention, so you start them on doxazosin, and multiple medications just keep getting piled on. You started them on ferrous sulfate, that led them to develop constipation. You gave them senna, that gave them diarrhea. Then you added Lomotil or Imodium to help with that diarrhea without even once asking or looking into what medications they're on and if all of what you're seeing could be a medication side effect. The Beers list and the start and stop criteria by the American Geriatric Society, which kind of helps us understand what the medication prescribing pattern should be like. So when you look at the potentially inappropriate medications for this particular patient, they're on clonidine 3 times a day, they're on doxazosin, increasing the risk for falls, they're on lorazepam, they're on zolpidem, too many sedating agents for one patient. So you want to clean up their medications. And you want to see, okay, why are you on aspirin and Plavix, on aspirin or clopidogrel for that matter, if you have atrial fibrillation and no prior stroke. So if you want to give aspirin for stroke prevention in a non-valvular AFib patient, then by all means, either give them just aspirin alone or change it to a direct oral anticoagulant like apixaban or warfarin for that matter by stopping the aspirin. Ferrous sulfate should not be 3 times a day because that would certainly lead to constipation. Once a day is just fine. So you clean up the patient's medication list. Just leave them with aspirin, amlodipine for blood pressure, ferrous sulfate for anemia, and just a stool softener for constipation that may come with the ferrous sulfate. So start medications that are important and relevant to the patient and stop the other medication that the patient does not require anymore. The start and stop criteria are important to help. If you're starting something, make sure that you have reviewed the medication list and are ready to stop a medication as well, so that you're not adding on to their medication list and risk of complications and falls. All right. I think this could be the final case, and that is a few days of bed rest. Now, an 80-year-old farmer is admitted for pneumonia, and he's anxious about being hospitalized for far too long, but he feels he could use a few days of rest so he can recover quickly. Now, functional baseline, he's independent, gets up, moves around, does all his daily living chores all by himself, but uses a cane to move around. So during his hospitalization, approximately what % of time is he likely to spend standing or walking in the hospital? What does the data say? So one thing I want you all to remember is that immobility in the hospital setting is very common, and it's a big deal. What % of time does the patient stand or walk in the hospital? Only 3%. Can you imagine? Just 3% of the time they're getting up and walking around. So what the heck are they doing the rest of the 97%? Being in bed. So many times I've talked to patients who haven't left their bed because Nobody told me to get up. I didn't know that I could get up because I was hooked to this IV line, or I had these EKG leads attached to my chest. I didn't know that I could get up. So communication is important by telling your patients that after you have done a good falls assessment on them by doing the bedside mobility assessment test and a time get up and go, and have established that the patient is safe to walk around and does not have orthostatic hypotension, then prescribe them activity so that they're not bound to their beds. Each step in the hospital counts. So the more they move, the less the chances of mortality and risk of complications. And early mobility has benefits in patients with pneumonia. Um, uh, Lowers the cost of hospitalization and shortens the length of stay. What more do you need? The quicker you can get them all improved and better, you can get them out of the hospital and get them. So activity prescription, make sure that they're getting out of bed, at least having their meals up in the chair. Physical activity, getting up, moving around with family members, with physical therapy 3 times a day, and within arm reach fall precautions, meaning that a bell or a bar should always be, if they're at fall risk, then they should have someone close by to help grab them if they were starting to. And so when we are making our mobility assessment to support safe mobility and lower risk of falls in the hospital per American Geriatric Society, you want to check their orthostatic blood pressures and a time get up and go. So if the time get up and go test is more than 12 seconds, meaning that you are making them walk 10 feet and turn back, and that is more than 12 seconds, that the patient is at a higher risk of falls. Always, I mean, if I'm worried about a patient falling and there are multiple medications, I always check their orthostatic blood pressure laying down and standing up after 3 minutes to make sure that orthostasis will not contribute to their fall in the hospital. I always ask them about urinary incontinence, any troubles with their vision. Do they have their glasses on them? Do they have hearing impairment? Do they wear hearing aids? And do they have them on while they're here in the hospital? And ask about depression. If patients are not getting out of bed, they prefer being in bed with their blankets over them, barely interacting with anyone. It could either be that they feel socially isolated because of sensory impairment, vision or hearing loss, or they're simply depressed and nobody has ever spoken to them about it. Again, extrinsic factors and risk for falls would include psychoactive medications, sedative, hypnotics, opioids, anti-diabetic medications with risk of hypoglycemia, and environmental factors like just clutter, shoes, stairs, rugs laying around the house. And it takes an interdisciplinary team to make the environment safe for patients' mobility, with physical therapy, nursing to give you guidance of what the patient's underlying baseline activity level was compared to now. Pharmacy can help review your medications. Podiatry can help with any toenail clippings or any orthotics that they need for better and safer ambulation. So going back to all our cases one by one. So the first one with our lady with orthostatic hypotension, 82-year-old retired teacher. You assess that she had orthostatic hypotension, she had hyponatremia, and clearly she was hypovolemic and therefore having orthostatic hypotension. Again, let the patient's function be your guide as to how you control their blood pressures. If they're frail and medically complex, then a more conservative approach is better than an aggressive approach. If they're robust and active, then a target of systolic 140 to 150 is appropriate, and always monitor orthostatic vital signs, especially when you're adjusting or changing their blood pressure medications. Our second lady, who really had a delightful time after having cake, and a new diagnosis of diabetes. Hemoglobin A1C was 7.3. In managing somebody that old, you just want to first make sure that you're not doing any harm and are avoiding polypharmacy. Our patient with delirium after post-op day 2 of the hip repair, um, since that was acute onset, right after the surgery, multiple factors could be at play: pain, constipation, immobility, dehydration. Um, so look at all the risk factors, medications, sedatives, hypnotics, all could be contributing to patients' acute delirium. And then test inattention by asking them to tell you the months of the year backwards. The next case of the 92-year-old retired fighter pilot. Key issues are to review medications. I think one of the 5 M's that we talked about earlier, one of them is medication. And so if the patient comes to you, whether in the clinic or in the hospital setting, you have to make sure that you review their medication list. If they don't have their medications, if like most doctors, you cannot find the prescription legible, then just simply ask them to bring their prescriptions from home and their medications from home, so you can review how they take it, when they take it, and if they are of sound understanding of why they're supposed to take these medications. Simplify the medications, for heaven's sakes, if you can. I mean, the more you keep adding on to the medication list, the more the risk of their hospitalization and mortality. Therefore, get out of the prescribing cascade. If you prescribe something and they're having side effects, taper off or stop the drug rather than give something else to help with the side effects. And always keep fall precautions on your radar. Hospital mobility is very important. Again, elevated risk of functional decline in the hospital is always there, because we only see them moving about 3% of the time while they're in the hospital. So therefore, always make sure that you're keeping your patients functioning and encouraging mobility after you have made sure that their time get up and go and their bedside mobility assessment test establishes that they're safe to walk around and ambulate. Unhook them from Foley catheters, from wires, leads, IV lines, so that there's less things to tether them to their bed, and allow them safe mobility. Physical activity can be with nursing, physical therapists. Often it's safe to keep a gait belt around the patient so that you can hold them steadily as they're walking, but not support them. Just let them walk independently, whether they're using a cane or a walker or they're walking by themselves, but just have the gait belt around. So if they start to stumble or fall, then at least you have something to hold them by. And in conclusion, geriatrics is all about function, preserving function, physical function, cognitive function, and keeping the patient independent for as long as you possibly can. Always think about their functional and physiologic age. I've seen patients who are 50 years old and are in worse shape than many 80 years old who have kept up themselves very well. And again, a conservative approach in the very frail older patient is the best advice. Keep function as your goal. Avoid the prescribing cascade, as we talked about. Prevent functional decline, falls, and delirium by being proactive in their assessment as they come into the hospital or in your clinic. And then most importantly, do no harm. Rather than being too aggressive, always ask them about what matters to them, what are their goals, what do they understand of what's going on with them, and how would they want you to treat them. And then just help them get along their journey and keep them safe at home or in an institution or in the hospital where you're taking care of them. So with that, I conclude this presentation and I thank you for your time and attention. Hopefully in the future, I'll be uploading some more discussions and talks, which would be geared towards geriatrics and palliative medicine. So I appreciate your conversation, and thank you so much for your time.